Okay, sir. Okay, sir.
Good evening, everybody. This is Dr. Rajesh Raman. I'm a member of the Southzonal CME committee. I would like to first of all welcome the different people that have come. First of all, I would like to welcome the President, Dr. Ramakrishnan, Dr. Ramana Nirat, the Vice President, Dr. G. Suresh Kumar, the Honorary General Secretary, Dr. K. Jairam, the Treasurer, and Dr. Arvind, who is the Chairman of the CME committee, along with the other members. I would like to especially thank Dr. Jayant and Dr. Arun for accepting to speak on two different topics of addiction today evening. And I would like to specifically thank the chairpersons, Dr. Varghese Pannus and Dr. Vidhu Kumar from Kerala. Thank you. I now request the President, Dr. Ramakrishnan, to say a few words.
Good evening to all of you. Thank you, Dr. Raman, for organizing this meeting. Wonderful topics. And I thank my co-EC members, Dr. Irat, Dr. Suresh Kumar, Dr. Gangaram, Dr. Shahul, Dr. Vishal, and the CME committee, senior members of our IPS, for continuously supporting this WISER program. Today, 325 people have registered. That itself shows the success of our program, how much we are followed. The credit goes to the speakers and the organizers, like VK Aravind, Dr. Raman and all. They take much pain to organize, and the topics are also interesting and which is relevant for the clinical practice. And our aim of promoting young generation psychiatrists, that is happening, and that is showing result. And I'm very happy that today's topic, both are very much needed for this period, like alcohol dependence, which is recent advances. Every day people spend a lot of money on drinking, and researchers are also pouring billions of dollars for research to find new molecules, new avenues, how to treat. There is going in balance. But somehow alcohol takes over all our research activities. That's what is a common one. And I hope that our speaker, Dr. Jayant Mahadevan from NIMANS, you need not tell anything, very enthusiastic person to talk, right person to talk on this subject. And another problem what we have is internet addiction. That is again a big area. But one thing from my personal side, what I keep telling, we talk a lot about internet addiction. We talk about the strategies to prevent and everything. But my opinion is it should start from the family from the parents. Then only this thing can be solved. And we are doing a lot of awareness programs. I don't know how many people have been cured from this addiction. Is there any RCB? That is again a very big question. Research in terms of volumes, how much it has reached, how much people have succeeded in the procedures to treat the addiction, I don't know. So these are things that will be discussed by Dr. Arun Kandasamy, again, a great speaker and working on internet addiction. Thank you, Dr. Arun Kandasamy. And I am also happy that this session is being chaired by two professors of psychiatry from Kerala, Dr. Varghese and Dr. Vidhu Kumar. I think Vidhu Kumar is very much fond of this addiction medicine. So I hope these two people will moderate the session in such a way that it will be lively. And without much ado, I think I should hand over the mic to the organizers of WISER. Thank you all. I thank the sponsor for the program and Sun Pharma for their continuous support. Have a great day. Thank you.
I think the chairpersons can take the role, Dr. Vidhu Kumar and Dr. Varghese Ponnu, sir. You can give your comments, and before handing over the mic to the speakers, you can start your session now.
Before starting the session, I would like to honor our chairpersons, Professor Vidhu Kumar. This is our humble memento to you, which will reach you within 2 days to you. Because of the online project, I am showing this, and it will reach you. Thank you, Dr. Vidhu Kumar, for being here. And I am also happy to honor Professor Varghese for this
Thank you.
wonderful
Thank you.
program and your enthusiasm in continuing to support our WISER program. He is also part of this awards committee. Thank you, Dr. Varghese.
Thank you, Dr. Ramashan, President of IPS South Zone, Dr. Arvind, Chairman, CME, my co-chairperson, Professor Vidhu Kumar, Dr. Jayant, and Dr. Arun. I am extremely delighted to chair this session on a very lively topic, which has already been introduced by Dr. Ramakrishnan. Both the speakers, they are very eminent clinicians and academicians from a place, the Center for Addiction Medicine in Immense, the premier institute in our country, and of course the Center of Excellence, which deals with addiction disorders. With regard to these topics, alcohol dependence, it always it will ignite interest in clinicians, because patients who are treated even in the best centers, even the most motivated patient is likely to relapse. Relapse is the rule. Even though we have our pharmacological as well as psychotherapeutic or non-pharmacological approaches to handle the relapse part, we all of us will agree that the results are not that very great. A lot of things have been happening in the field of addiction, especially with regard to alcohol and other chemical addictions, and also the newly introduced concept or newly emerging problem of the behavioral addiction. DSM-5 has actually united the abuse and dependence, everything under the use disorder, the substance use disorder. So that is, nosological advances are there. Craving has been introduced as a part of a diagnostic criteria for addiction disorders. So on the nosological side, there are changes. And on the pharmacological side, we find there are several new molecules getting introduced. Several new targets are being identified apart from the conventional GABA and the dopaminergic. We target the 5-HT3 receptors, we target the cannabinoid system, the orexin system. So all these new targets emerging and better understanding of the neurobiology of addictions. It is definitely, I think we can hear from the master, Dr. Jayant, about the newer advances in alcohol addiction management and the newly introduced or newly emerging concept of neuromodulation in the treatment of addictive disorders. I understand that Dr. Jayant has done some work on transcranial RTMS in patients with alcohol addiction. I don't know about the other condition. And the second topic on the internet gaming disorder, which has again found a place in DSM-5, the nosology of still which is unclear. And I have heard from sources that NIMANS is having a special clinic called SHUT, Service for Healthy Use of Technology, done under the aegis of CAM. So we are all eager to hear from Dr. Kandasamy about your experiences on internet gaming disorder. Many young children, they even find it, they think that their they got into a lucrative business opportunity or a professional opportunity, which we do tend to consider as a disorder. I don't have any much expertise in this area. So I think that my co-chair Vidhu will just say a few words, and straight away we can start the session, and we are eager to hear from both Dr. Jayant and Dr. Arun Kandasamy. Thank you. Over to you, Dr. Vidhu.
Respected President, the speakers, the organizers. At the outset, let me thank the Southzone for giving me this opportunity to chair this session. And I'm not prolonging my introductory speech. Probably in alcohol dependence, as Dr. Varghese said, probably preventing a relapse. What recent advances has to contribute to relapse prevention? That is probably everybody will be looking forward. And second thing, in internet addiction, even after 25 years of introducing the concept, it has failed to reach the nosological status, the construct, except for the gaming part. Internet addiction has not reached the, has not assumed a nosological construct. Why is it so? Whether advances in neurobiology will be able to help to evolve this construct. We want to hear from you, both Dr. Jayant and Dr. Arun. Thank you.
Okay, so a very good evening to everyone who's present here. Honorable chairpersons for this session, Dr. Varghese and Professor Vidhu Kumar and Professor Varghese, and all the organizers, the President of IPS South Zone, Professor Ramakrishnan, as well as Dr. V.K. Aravind and Dr. Rajesh, as well as the sponsors for today's event. It's indeed an honor for myself to be able to talk to you today on this quite important area, as has already been mentioned by the two eminent chairs for this session. It is a very vast area, alcohol dependence, recent advances. And so obviously, given the want of time, wherein we just have about 20 minutes to half an hour to discuss this vast area, I will be focusing primarily on the pharmacological advances that are there as far as management of alcohol dependence. Some of it will be relevant to us in our day-to-day practice. Some of it will be probably more relevant in terms of our understandings and about things that are going to happen in India, say in the next 5 or 10 years. But I hope that it will be a useful session for you. So I'll just share my screen, just one second. Okay. Are you all able to see my screen? You can just give me a thumbs up if you can see. Okay, yes. Great. Wonderful. Okay, so let me introduce myself. My name is Dr. Jayant Mahadevan. I have done my DM in Addiction Psychiatry from NIMHANS, and I'm currently working as Assistant Professor of Psychiatry at the Center for Addiction Medicine at NIMHANS. Now, whenever we are talking about a topic on alcohol dependence, these are some of the key areas that we need to cover. One is, of course, the neurobiology. The other is with regards to assessment. Finally, pharmacological and psychological interventions. Now, as I had mentioned, given the want of time and given the vastness of the topic, I am not going to be able to touch in great detail about all of these areas, except for specifically probably a little bit more about the pharmacological and other somatic interventions for alcohol dependence. But that being said, I think it is important that we should just briefly talk about neurobiology of alcohol dependence. These are all areas which most people who are familiar with the literature over the last 10 to 15 years will be aware of. But I thought it would be good to have a quick revision. So as we know, the stages of the addiction cycle as given by Koob and Volkov, the 3-stage cycle which moves from the binge intoxication stage where the neuroanatomical structures include the ventral striatum, the dorsal striatum, the globus pallidus, and thalamus. And that basically subserves the part of the addiction cycle which is associated with the initial euphoria or rewarding effects of drugs, as well as the formation of habits over time. Then you have the next stage of the addiction cycle, which is the withdrawal negative affect stage. The structures which are involved are once again, the ventral striatum, as well as the amygdala, the bed nucleus of the stria terminalis, which are known as the extended amygdala. And these are associated with essentially the manifestations which are there during withdrawal, and that includes physiological signs of withdrawal as well as the motivational withdrawal state, which includes dysphoria and other negative emotional states. And then finally, we have got the preoccupation anticipation stage, which corresponds roughly to the craving part of or the relapse part of the whole addiction cycle. And the structures which are involved are primarily the anterior cingulate as well as the prefrontal cortex. So again, this has got more to do with executive dysfunction and control over craving and so on, right? So after this quick review, this is important to understand because in addition to the structures which are involved, there are also different neurotransmitters which are involved. As Professor Varghese had already mentioned, obviously, when it comes to dealing with the binge intoxication stage, the primary neurotransmitter that is implicated is obviously dopamine, although most drugs of abuse and some addictive behaviors also ultimately converge on the dopamine pathway through different neurotransmitters. As far as the withdrawal negative affect stage is concerned, that is where there is a great deal of interest in terms of identifying newer targets at a synaptic level to be able to deal with alcohol dependence. And so the neurotransmitters, again, dopamine, because there is a dopamine deficit state in the withdrawal negative affect stage, but also some of the other neurotransmitters which are associated with both the hypothalamic as well as the extra hypothalamic stress systems. And those include things like corticotropin releasing factor, dynorphin, endocannabinoids, neuropeptide Y, neurokinins, and so on, as well as orexins and hypocretins. So these are some of the other neurotransmitters which are actually associated primarily with the withdrawal negative affect stage. And so there are some medications which have been or are in development and have been used which target some of these neurotransmitter systems as well. And when it comes down to dealing with the preoccupation anticipation phase, the primary neurotransmitters that are involved are dopamine and glutamate. So this is a table which just summarizes some of these findings that are there. And I think this needs to be something which we have to keep as a kind of template which we can use to be able to understand things going forward. All right. Now, with that very brief update about neurobiology, I'm not actually going to go into a lot of the updates about neurobiology because, again, I think that will involve a whole separate session because we are talking about molecular genetics, epigenetics, and so I'm not really going to go into that in a great deal of detail because it may not be very relevant. But we will quickly move on to the next part, which is with regards to the assessment of alcohol dependence. And of course, we all know that there are standard strategies and techniques. Obviously, history, examination, investigations are all very, very important as far as assessment is concerned. But I thought that it would be interesting to talk about some of the recent advances, if you want to put it that way, with regards to assessment of alcohol dependence. Very briefly, just to kind of incite some interest in this so that you guys can think about it in the future as well. So with regards to assessments, actually, this is something which is an area of lot of research and a lot of interest, and that is with regards to identifying ongoing alcohol use or identifying alcohol intoxication using different kinds of biosensors. And this is something which there's a review that was done in 2019, which has looked at mobile alcohol biosensors. While these are at present mostly in the developmental stage, and they are being used primarily as outcome measures, say in research and clinical trials, this is something which is potentially an area of a lot of interest because having, say, a wearable device which will be able to identify alcohol in the sweat. So that is one of the devices that is used. Then there are other measures which look, so gyroscopes, which are able to actually identify that a person's hands are moving in a particular way or can identify withdrawal symptoms. And so all of these could potentially be interesting ways to be able to assess, or ecologically valid ways to be able to assess ongoing alcohol use in the future. And hopefully there will be some clinical translation about this in the next few years. The other very interesting thing which I wanted to talk about, just to kind of put it out there as well, is the role of virtual reality. And we all know about cue reactivity paradigms. Cue reactivity paradigms are essentially presentations of cues to individuals who have alcohol dependence, and as a measure to be able to elicit craving, either physiological correlates of craving in terms of changes in pulse rate, galvanic skin response, or else subjective measures of craving. And so obviously initially you used to have cue reactivity paradigms using photographs. Then subsequently people moved on to developing cue reactivity paradigms paired with MRI, which is MRI-based cue reactivity paradigms. And the new area as far as that is concerned is with regards to virtual reality aided cue reactivity paradigms. And this is a review done in 2020, which talks about virtual reality, both in assessment as well as treatment of addictive disorders. And I think it's something which is again going to be an interesting area because again, more ecologically valid, you will be able to probably provide cues which are much more contextually relevant to the individuals with alcohol dependence. And a few of the studies, there have been about 5 or 7 studies which have been done in patients with alcohol dependence. And they have actually been able to elicit very realistic measures of craving using virtual reality. And so that is one challenge that we always usually have in patients with alcohol use disorders. And that has been to be able to get ecologically valid measures of craving. And so this might be an answer to some of that. The second important thing which I would like to talk about, again, in terms of a recent advance in terms of assessments, is with regards to how we understand outcomes in individuals with alcohol use disorders. And I think Dr. Varghese had mentioned about how despite medications having been around for a very long period of time, relapse is the rule rather than the exception in individuals with alcohol use disorders. And so for a large number of us, relapse is seen as a failure of treatment. And there is a large amount of new data which has been there. And actually, it's data which has been accumulated over the last 2 or 3 years, including a number of these reports which have been published in leading journals like Addiction over the last 2 years, which have talked about how we need to have a different paradigm in terms of understanding outcomes in patients with alcohol dependence. So traditionally, the kind of outcomes that we've had, which is abstinence, days of abstinence, or abstinent versus non-abstinence, things like percentage of heavy drinking days, things like time to relapse, might not be the ideal kinds of measures for a various number of reasons. And so these studies, you can look at the titles: Reconsidering Alcohol Treatment Non-Responders. What is the kind of psychosocial functioning amongst heavy drinkers 3 years following treatment? So these have looked at a lot of RCTs, prominent RCTs, which have been done in the area of pharmacotherapy of alcohol use disorders like Combine and some RCTs from UK. And they have actually tried to identify whether there are other markers that can be there to be able to identify people who are treatment responders versus treatment non-responders, and how that translates into, say, outcomes like psychosocial outcomes and so on. And actually, very interestingly, people have found that there are a subset of individuals who may continue to drink but may still have outcomes similar to people who are not drinking. And so people have used things like latent class analysis to be able to analyze this. And so this is another interesting area to look at. Another very interesting area to look at in terms of outcomes is this World Health Organization risk drinking level. And that reductions in those might also be meaningful clinical endpoints in terms of being able to assess the efficacy or assess the success of your treatment with alcohol use disorders. And so these are things which I think we should also keep in mind when we are looking at pharmacotherapy for alcohol use disorders. So with that, I'm actually going to move into the meat of the topic, which is with regards to the pharmacological interventions. And I'm not really going to talk a lot about this. We all know the currently FDA-approved medications, disulfiram way back in 1949, naltrexone, acamprosate, and naltrexone injection, 380 milligram IM once monthly injection, which is not available in India, but has been approved for treatment of alcohol use disorder by the FDA. So these are the agents which are used, I think, for most of our practitioners who see patients with alcohol use disorders, they would be familiar with these medications. And so given, again, the want of time, I'm not really going to go into too much details about that. I'm going to actually move on to the next line of agents, also agents that we use, some of which we use very, very commonly, some of them which are a little bit newer or repurposed drugs as such, and understand a little bit about that and probably see whether we can apply some of those in our clinical practice. So nalmefene is actually the most promising agent amongst the non-FDA approved drugs. It is an inverse agonist at the mu-opioid receptor, but also an antagonist at the delta opioid receptor and a partial agonist at the kappa opioid receptor. It has a longer half-life and no liver dysfunction when compared to naltrexone. And while it has not yet been approved by the FDA, it has an approval by the EMA, that's the European Medicines Agency for Alcohol Use Disorders, since 2018. At a dose of 18 milligrams once daily, or as needed 1 to 2 hours, very similar to how you use naltrexone using the Sinclair method, is the dose that is used. And adverse effects include common adverse effects like nausea, dizziness, insomnia, headache, vomiting, and fatigue. Again, should not be used in individuals who are either receiving or expecting to receive opioids. As I said, very promising in terms of outcomes. Meta-analysis has shown that there's been a reduction of heavy drinking days per month, and that these changes persist up to 6 months to a year. And there is also a decrease in total alcohol consumption that has been noted to be present with nalmefene. And there are a number of clinical trials in different parts of the world which are currently ongoing with regards to evaluating the efficacy of nalmefene. Unfortunately, nalmefene is not yet available in India, but again, hopefully something to look forward to in the future. Baclofen is something which I think we are all familiar with, in the sense that it seems to have become a part of the pharmacological armamentarium of clinicians treating alcohol use disorders in India, at least. It is, of course, popular in other parts of the world, not in the US, but it's popular in Europe as well as in Australia. And in fact, France has fairly recently also approved its use for treatment of alcohol use disorders. There's no approval in any other parts of the world. As we know, it's a GABA-B agonist. GABA-B receptors are prominent in the limbic system, and stimulation of the GABA-B receptors decrease excitatory neurotransmitters as well as modulate dopamine in the mesolimbic dopamine pathway. It's been seen to lead to reductions in reinforcing properties of alcohol, and also has some impact on anxiety and alcohol withdrawal. The doses that are used, at least 60 mg of baclofen, although a number of the trials that have been that have looked at baclofen have looked at much higher doses, even up to 250 milligrams of baclofen. Typically preferred in our population, from our experience, usually the doses that we go up to are anywhere between 60 to 80. And some individuals are there wherein we've tried doses between 100 to 150 milligrams of baclofen as well. I personally have not gone on doses higher than that. Lot of adverse effects, some common, some a little bit less common, but quite severe. The common adverse effects include constipation, dizziness, drowsiness, fatigue, headache, nausea, sleeplessness, and pedal edema. Pedal edema is something which can occur quite often with baclofen, and it is something which is quite distressing as a side effect for individuals. In addition to this, some of the more uncommon side effects, but quite serious, are severe allergic reactions. Urinary complaints. So a lot of people actually complain of dysuria when they are using baclofen. Agitation and chills, and sometimes a loss of muscle tone and seizures can also be noted to be present with baclofen. And generally, I think one of the concerns with baclofen the world over is with regards to some of these adverse effects. Although in our clinical practice, we don't probably see that much of it, but it probably needs to be evaluated in a more systematic way. And as a consequence of that, actually, a number of people have tried to look at other allosteric modulators of the GABA B receptors, including racemic mixtures of baclofen. So there is a current RCT which is running, which you can look up in clinicaltrials.gov, which actually looks at something called R-baclofen, which is a racemic mixture of baclofen, which is seen to have probably not have some of these kinds of adverse effects which are associated with the usual baclofen that is there. And so this is basically the Cagliari statement. A number of researchers who've been doing a lot of work on baclofen from Italy, who are now based in the US, have actually released this statement saying that there is quite a lot of evidence to actually suggest a point towards the potential efficacy of baclofen. And this definitely calls for additional larger studies, but also emphasizes the importance of tailoring doses based on safety, tolerability, and efficacy. And I think that's a line that we need to really keep in mind when we are treating individuals with baclofen. I do anticipate that a lot of the practitioners here would be using baclofen in their practice. And I think these are the concerns that we need to keep in mind when we are prescribing baclofen. The other agent, which is somewhat related to this, it's not really a recent advance. I mean, in the sense that it has been used in, particularly in Italy and Austria, in the continent of Europe, for almost 20 years right now. And in fact, there are some very interesting papers where they have actually prescribed it to large numbers of individuals with alcohol use disorder. When I say large numbers, I'm talking in terms of lakhs of patients with alcohol use disorders. And we know it, I mean, the other name for sodium oxybate is gamma hydroxybutyrate, and GHB, as some of us may know, is also an agent which, when it is used on the street, is a drug of abuse. But individuals who have actually used sodium oxybate in practice seem to report very, very good results. And very recently as well, so the study which is there below, right? So the one in 1996, that's an open multicentric study. That was the first study which looked at this sodium oxybate in 179 alcohol-dependent subjects. And they found that there was significant incidence of complete abstinence in individuals with alcohol dependence. And the same group, which includes Giovanni Addolarato, has actually looked at the efficacy and safety of sodium oxybate in alcohol-dependent patients with a very very high-risk drinking level. And they've actually talked about significant increases in abstinence rates compared with placebos and risk ratios of 6.8 in favor of sodium oxybate. So that's huge. I mean, a risk ratio of 6.8. I'm not talking about a number needed to treat. We're talking about the likelihood of response being so much higher is something which is quite miraculous in that way. But obviously the concerns are with regards to abuse potential. And even these trials have actually reported that a number of people used to escalate their doses. So the 96 study talked about 10.1%. So that's almost 1 in 10 individuals who actually escalated their dose and were at a potential risk for abuse as well. But this is another interesting agent, which at least in research settings is something which we will hope to study at some point of time. Now, moving on to another GABAergic agent. So again, I'll tick off the standard ones first, which focus on some of the known molecular targets, and then we will move on to some of the more exotic stuff. So Gabapentin is another agent which inhibits voltage-gated calcium channels and therefore indirectly modulates GABA. Doses, there is a wide dose range which has been actually tried in clinical trials, from very low dose 300 mg to up to 1200 to 1800 mg. So the dose that is generally recommended is 300 to 600 mg thrice daily. And actually, quite interestingly and surprisingly, when we were going through the evidence, I mean, when we were actually going through the guidelines 2 or 3 years ago, we found that it had popped up in the APA guidelines as a second-line treatment for alcohol use dependence patients. And then actually that led us to go back and look at, do a little bit of a literature search with regards to gabapentin. And so particularly in the US, there seems to be a lot of interest in looking at gabapentin. Although the first trial that I've mentioned there in 2018 was actually conducted in Thailand. And there, a very low dose of gabapentin, 300 milligrams, actually significantly reduced the percentage of heavy drinking days and weekly drinking days. A more recent trial, which very recently concluded and was published in late 2020 from a group in the US led by Ray Anton, talked about a dose of 1200 milligrams significantly associated with a decrease in heavy drinking days and an increase in total abstinence. And they found these effects were much more pronounced in individuals who had more alcohol withdrawal. And so a recent meta-analysis, which has also looked at gabapentinoids, which include gabapentin as well as pregabalin, point towards the fact that people who have more alcohol withdrawal or prolonged alcohol withdrawal might actually benefit from the use of gabapentin. And so that's something which we can potentially keep in mind. People have also tried to look at a long-acting preparation of gabapentin called gabapentin enacarbil, and that is something they've recently concluded a trial about a year ago, but that was not found to be significantly better than placebo. It was a large RCT, but that was what we had seen with gabapentin. Another agent which seems to have really come back into vogue right now, with a lot of people actually looking into it, is topiramate. Now, topiramate again is something, the proof of concept studies were actually done by Banco Lee Johnson back as far back as late 1990s, early 2000s. And people didn't really take to it very much at that point of time. From a molecular standpoint, it primarily it antagonizes glutamate receptors, both AMPA and kainate, as well as facilitates GABAergic activity, broad range of actions, blocks L-type calcium channels as well as voltage-dependent sodium channels, and it inhibits carbonic anhydrase, which is what is related to some of its adverse effects as well. For alcohol dependence, the doses that are required are quite high, higher than what is usually used for seizures, 200 to 300 milligrams per day in a BD dose, and a lot of side effects, dizziness, paresthesia, psychomotor slowing, memory or concentration impairment, nervousness, taste perversion, pruritus, and weight loss. That being said, despite having a lot of these kinds of side effects, the APA guidelines in 2018 offers topiramate to moderate to severe alcohol use disorder patients who have a goal of both reducing alcohol consumption as well as achieving abstinence. And it seems to help with both of these, which is wonderful. It can also be given to people who prefer topiramate or those who have not responded to naltrexone or acamprosate. So again, it seems to be a good second-line agent which is used in individuals with alcohol use disorders. Again, very anecdotal, but it seems to while we find that it takes time in terms of titrating the doses, it seems to help in our patients with alcohol use disorders as well, severe alcohol use disorders. So as I'd mentioned, the one consideration that one needs to keep in mind, I've not put that on the slides, but keep in mind that when you're titrating the dose of topiramate is in that sense very similar to lamotrigine, insofar as you would want to titrate the doses very, very slowly, because if you titrate them very fast, then you're likely to get more adverse effects. So 25 mg start off with and build it up by 25 mg probably every week, and reach a dose of about 100 mg, and then subsequently after that probably you can titrate by increments of 50 mg, and that should be based on tolerability of the individual. It's something that is very freely available here in India. It's actually more reasonable than naltrexone as well as acamprosate and baclofen if you give baclofen at a good dose. And so that is potentially an agent which can be considered in individuals with moderate to severe alcohol use disorders in our practice as well. Zonicemite is another agent which has a similar receptor profile to topiramate. And so as a consequence of that, people are kind of looking to explore that. It also seems to have a slightly better side effect profile. And so compared to placebo, this is an old study which was done, which looked at zonicimide at a dose of 500 mg per day, again seemed to reduce number of heavy drinking days, drinks per week, as well as alcohol craving. More recent trials have also been done, and they are ongoing at present. Ondansetron, because again we talked about looking at the serotonergic system, it's a 5-HT3 antagonist. Again, studies have been done way back, but again there has been a resurgence in interest, and I will tell you why somewhat a little bit later. And primarily, again, it is seen to help with people who have a high drinking as well as early onset alcohol use disorder. The doses that are used are actually much smaller than the antiemetic doses. So 4 micrograms per kg given BD. So the best dose in the trials that were done, they tested 1 to 16 micrograms per kg doses. The most effective dose was 8 micrograms per kg. That is 4 micrograms BD. And some mild side effects are there, but generally very well tolerated. Now moving on to some of the things that maybe we may not have heard of. Prazosine and Doxazosin, these are alpha-1 adrenergic receptor antagonists. We do know a little bit about how Prazosine has been used in PTSD. So the proof of concept for these studies actually came from individuals with comorbid PTSD and alcohol use disorders, primarily from the US Veterans Administration, because they have a lot of people who have PTSD and alcohol use disorders. And so what they've actually found is that Prazosine at a dose of 16 milligrams per day in 2 to 3 divided doses seem to actually help not just with PTSD symptoms. In fact, ironically, it didn't help that much with PTSD symptoms, but it seemed to help quite a lot with alcohol use symptoms. And that is why there have been some trials which have looked at this going forward as well. Doxazosin, again, this is another agent. Both Prazosine and Doxazosin, of course, have also been used for treatment of benign prostatic hyperplasia. And again, at a dose of 16 milligrams per day, this is a single dose for Doxazosin. And there is a lower frequency of the kind of adverse effects that are there with Prazosine. A couple of the trials which have looked at their effects in alcohol use disorders say that it seems to be moderated by pre-treatment BP. So people with higher baseline blood pressure prior to treatment initiation seem to do better with Prazosine and Doxazosin. There's been a recent meta-analysis which has been done, published in 2020 as well, where there seems to be some effect on alcohol consumption. So this is also an agent which can potentially be looked at, and particularly if you're able to identify individuals with comorbid trauma and so on. Another agent, I know antipsychotics is something which a lot of people have thought about with regards to alcohol use disorders. Generally, not very good efficacy. In fact, we know that the typical antipsychotics might actually worsen substance use disorder and increase substance use. But there has been some evidence to look at aripiprazole, and this is something which has again been coming up again and again, and there are a few more trials which have been looking at it. So at a dose of 15 milligrams per day, it seemed to decrease alcohol self-administration in those with low self-control, as well as delayed the return to drinking in those with high impulsivity. And this effect seemed to be moderated by the DAT1 polymorphism through alcohol Q-elicited striatal activations and self-administration. So basically what it said was that primarily there might be an interaction between the genotype as well as Q reactivity in the striatum, which might be moderated by aripiprazole at a dose of 15 milligrams. They've tried higher doses as well. Higher doses don't seem to be doing much better, and they lead to more adverse effects. So this is something which can potentially be tried out, and there are more studies which are looking into this. Varenicline is another agent. Again, we know it primarily in the context of smoking cessation. Again, people tried it in individuals with smoking cessation who have comorbid smoking and alcohol use, and saw that it also had some impact on alcohol use disorders. Again, reduced drinking, craving, self-administration, and subjective reinforcing effects of alcohol may be effective in individuals with less severe alcohol use disorder and comorbid tobacco use. And actually 2 studies have replicated this about it being more effective in men rather than women with heavy drinking. And the dose is similar to what is used in tobacco cessation, which is 2 milligrams per day. Now, some of the more exotic agents, vasopressin, that is V1B receptor antagonist, ABT436. There is a single double-blind trial which has looked at this, and it has found a greater percentage of abstinent days. I actually looked at whether there is any evidence for some of the other typically available vasopressin receptor antagonists, that is the Vaptan group, Tolvaptan, Conivaptan, all of those kinds of things. But for some reason, I was not able to identify any trials in alcohol use disorder. So maybe we may need to look into this a little bit more, and these could be potential areas for study in the future. Basically, the idea is that vasopressin is actually associated, so vasopressin antagonism is actually associated with decreased levels of anxiety and managing withdrawal, prolonged withdrawal in individuals with alcohol use disorders. And that's the idea of trying a vasopressin receptor antagonist. Now, a whole lot of other agents have also been tried in terms of, again, looking at being able to handle some of these neuromodulators, which have looked at being able to handle some of the withdrawal negative affect related issues in alcohol use disorders. So mifepristone is a glucocorticoid receptor antagonist. It has been tried for improvement of cognition and affective symptoms, and there's some preliminary evidence. Again, these are all proof of concept studies. Again, ibudilast is a neuroimmune modulator. It comes down to the immune theories of alcohol dependence, and it inhibits phosphodiesterase 4 and 10. And again, proof of concept studies have looked at reduction in alcohol-induced stress and cue-related responses. These have all been tested in animal models. These are proof of concept studies in humans. So these are things which are likely to actually emerge in the next 5 to 10 years. Again, cycloserine, oxytocin, N-acetylcysteine, ghrelin receptor inverse agonists, neurokinin antagonists, as well as nociceptin receptor antagonists, all in the pipeline over the next 5 to 10 years. Again, the primary areas that are focused as far as this is concerned is, again, the withdrawal negative affect stage, so-called the dark side of addiction by George Koob, as well as some things to do with relapse, because we know that the withdrawal negative affect actually predisposes to relapse as well. Another few things, I just have 2 or 3 more slides. Ketamine is another very interesting agent which has been explored in individuals with alcohol use disorders. This was a paper that was published in the American Journal of Psychiatry in 2020, February. And this is a single intravenous administration of ketamine in a small sample of individuals compared to control group which received anesthesia with midazolam. And there was a significantly increased likelihood of abstinence, delayed time to relapse, and reduced likelihood of heavy drinking days. The observation period for this single administration of ketamine was 21 days. So they observed this for 21 days after this single administration. And this was an RCT as well. And so that is, again, an area which probably merits some amount of exploration, because ultimately ketamine is an NMDA receptor modulator antagonist, and it can be associated with undoing some of the memory-related issues, consolidated memories which are associated with relapse to alcohol use disorders, and that is what the potential mechanisms could be. Now, coming to neurostimulation, like Dr. Varghese had mentioned, RTMS is something which has been tried a lot in individuals with alcohol use disorders. Primarily, they've looked at high-frequency stimulation to the DLPFC, and outcomes have been fairly variable. My research work during my DM was also on RTMS, but on a different protocol of RTMS called theta burst stimulation, again to the dorsolateral prefrontal cortex. And there was some early evidence of some changes between 2 of the groups. We had studied 4 groups in this. And I'm not going to go into a lot of details about this for want of time, but again, some promising evidence with regards to RTMS. There's also a lot of exploration of using deep RTMS, that is RTMS, say, to structures like the medial prefrontal cortex to target craving, as well as the insula, which is something which is being explored in individuals with alcohol use disorder. As far as TDCS, which is another brain stimulation method, again, I'm quoting a study which was done here at NIMHANS, where they have looked at right anodal and left cathodal DLPFC TDCS, which again they looked at both functional connectivity using resting state fMRI as well as looking at clinical measures. And they found that there was an overall improvement in whole brain network efficiency as well as interregional connectivity within local prefrontal subnetworks. So again, the reason why I'm mentioning this is because the proposed mechanism of actions for RTMS and TDCS to the prefrontal cortex is mainly got to do with improvement of executive functions. So you're looking at executive control over craving actually improving, executive control in terms of impulsivity improving with these kinds of protocols. So those are the kinds of treatment targets that have been there using brain stimulation. Right. Finally, another interesting area is actually the interaction of receptor polymorphisms or pharmacogenetics along with treatment response. Now, most of the common agents that includes naltrexone, topiramate, ondansetron, as well as acamprosate have been studied in terms of pharmacogenetics. In fact, there are two current ongoing large studies, pharmacogenetic studies, which are ongoing for evaluating pharmacogenetic interactions of topiramate as well as pharmacogenetic interactions of ondansetron, both by the author mentioned here, that is Henry Kranzler. And this is based on some preliminary evidence, which again said that this particular polymorphism in the GRIC1 gene was associated with fewer drinking days in individuals who had the CC genotype as opposed to the AC or the AA genotype in individuals who are treated with topiramate. Similarly, the 5-HTT long polymorphism, that is the LL genotype of that, was seen to be associated with significant lower drinks per drinking day in individuals treated with ondansetron. And so this is again an interesting area of research going forward. So pharmacological options of long-term management of AUD are expanding, but there is still a lag as far as new drug research is concerned. And that is related to the fact that very often drugs which get tested in preclinical models don't actually transition to clinical trials. And there are various reasons for that, which I'm not going to go into right now. The selection of an agent ultimately needs to be personalized and has to be based on multiple associated factors. And always, while we've not talked a lot about psychosocial interventions, I think ultimately a good psychosocial intervention and a psychosocial management needs to be part of any plan for individuals with alcohol use disorder. My dream, I mean, in the sense, in the future directions, what one would like to see is probably a kind of situation wherein you have a number of predictors which you have at baseline, which would include clinical, genetic, neuropsychological, and imaging markers, which would, taken together, be able to help us to understand whether this person would respond to a particular kind of treatment. And so then we give that treatment and then actually assess outcomes, not just as abstinence versus non-abstinence, but outcomes in various ways, including functional outcomes. And so that would be the ultimate framework for being able to actually understand and treat individuals with alcohol use disorders. Thank you very much for a very patient hearing. That's my email if you would like to contact me.
Vidhu? Vidhu, you are not audible.
Now it's okay.
Yeah, now it's audible. Okay.
Okay, the next speaker can start his presentation, and I think we can take questions together.
Yeah.
Is it okay?
Yeah, we'll do that. We'll have the questions after both sessions are over.
Okay, over to Dr. Arun.
My screen is visible, sir?
Yes.
At the outset, I would like to thank the President, Dr. Ramakrishnan, and all the office bearers and the coordinators of the CME for inviting us for this wonderful teaching program. We are you're honored by your invitation. I'll straight away go into the topic per se. I have this conversation with Dr. Raman, and he suggested that this topic, let it be more of clinical. And again, the research hasn't reached the threshold of giving enough evidences on various areas as such at this point of time. So I would like to keep it clinical. To introduce it, the clinical description and the diagnosis, as Dr. Vidhukumar had pointed out, it's quite questionable. When we trace the history back into this whole internet addiction concept, it started with Dr. Ivan Goldberg, who in I think 1995, just before Kimberley Young started the work, he was a critic of DSM-4 and the diagnostic criteria which DSM-4 had brought in. So what he did is he had concocted on the basis of substance use disorder, he has concocted a disorder called internet addiction, and he wanted to it's a critique of the whole DSM-4 criteria per se. And he had put it in I think it's called psycom.net. I think that's not available at this point of time. It was a blog which he had created and he had put in over there. Like, to his surprise, he had received so many response that people are talking about their agony and their difficulties because of excessive usage of internet and uncontrolled usage of gadgets as such. Like, so it was interesting to see how to start with itself an atheoretical borrowing of the diagnostic criteria for substance use and then employ that for internet addiction. That has started the whole debate about what is the validity of this whole diagnosis per se, because it's atheoretical and we don't have anything specifically created for this disorder itself. It is more borrowed from the substance use disorder per se. And there were people who had built up their CV a lot with researchers on this area, just conducting, just giving screening instruments and conducting research on this in terms of prevalence in various areas. But there are specific timelines in which things have happened in favor of internet addiction. Some of the diagnostic criteria in terms of behavioral addiction and internet gaming disorder has happened at a later point of time. We'll come to it. But the question which Dr. Vidhukumar asked, the reason why it didn't take off is because of the reason of that the evidences to start with were anecdotal, and it's an theoretical approach, and there is no proper diagnostic criteria which was specific for internet addiction. The other most important thing is most of them had comorbid other psychiatric disorders too. Almost to the extent, if I had I had met with one of the South Korean researcher in terms of internet addiction. They do most of the research, and their problem seems to be very high when compared to us. And even in their population also, they are saying 60 to 70% of internet addiction disorder do have a comorbid other diagnosis too. So whether it is primary or secondary, whether it is a coping mechanism or it is a separate disorder, this debate is going on. If people are interested, I would suggest one reference material. This is a very beautifully written editorial, which is called as "Are We Over Pathologizing Everyday Life?" This was done by Joseph Bilyeu in Journal of Behavioral Addiction in 2015. And that article was supplemented by commentaries by almost around 10 luminaries in the field of addiction and related area who had worked for and against this whole concept of behavioral addiction per se. And it's a wonderful thing to read because we understand how people look at it and how things have developed. So to start with, the clinical description itself is questionable. Second, the available evidence specifically towards the assessment and the treatment is not a good guide for us to go over. And but the issue is there are a lot of people who approach us with this as a problem. So what are we to do? That's a question which we always get into. So I'll start with the models of care as such. As in substance use disorder, here also the models of care move from complete abstinence to harm reduction. Complete abstinence is being pushed over here also, and one of the complete abstinence model which is being employed in China is this is General Taoran, who runs the boot camp, military boot camp approach in China, which is basically to discipline people, and that's how he touts that things work better in China. And their problems are significant, and they put in a lot of restrictions on the whole internet usage by younger people as such. This is their approach, but that approach is not very conducive for the population whom we are facing, and the way in which internet is developing on an everyday basis, and it is getting into everyday life of us, especially we realized in the COVID times. It has taken over most of our life's activities per se. So everybody wants a digital interaction. How do we live without internet per se? So we need to look at the harm reduction model as a primary model per se. I'll just first summarize how this approach has to be from the clinic. How we approach, I'll talk about it. Like majority of the time with these clients, the younger lot goes with creation of rapport, because 60 to 70% of the time when they are being brought in the hospital, it is very difficult to create a rapport with them, because either it is against their thing, or some major problem would have happened and they have to be dragged to a clinic per se. So it is they come with a very negative mood to start with. So it's worth to spend time to create rapport with them. Only when we create rapport with them, we will be able to move on to do some interventions with them. Like, so it is most difficult, but it is the most important. And if we create a good rapport, I think 50% of the intervention should be over by then. And in the traditional approach that we should be able to create rapport in one session, but here it may not be possible. We need to do it multiple sessions. How do we do that? Again, the traditional approach of non-judgmental approach, and actively listening to them, what they are going to say, not being defensive about the whole issue. And since a family would come with a lot of pressure, and you also understand that significant amount of dysfunctions are noted over there, there is an urgency from our side also to intervene and change things. And if we push things, then they just move back and they don't cooperate. So we should not feel urged to change the behavior and intervene in a shorter run, because this is going to be a long-term problem. Many a times being honest work, because the kind of internet games which they do, and the kind of usages which they come, like for example, one of the girl whom we had treated some 4-5 years back, she had introduced me to the concept of this Facebook role plays and how it happens over there. Like I didn't even know what is that at that point of time. I think 6-7 years back. Now we need to be honest when we honestly asking them what is this, how they are doing. Like they are very happy, because there is the role reversal happen, and it feeds into their feeling that, okay, someone is willing to listen to me, someone is approaching it in different way. So being honest work, and it also feeds into their own narcissism so that they can open up. This is good for the first session, but subsequent sessions, we really need to be updated about what they have said to us. We may have to go back and do the literature. When they come back, we should have an equal level of knowledge, at least. Otherwise, they will not, the whole therapy will not take forward. in the assessment, I'll come into the details that like it has to be a holistic assessment, and it should include an entire lot of the person's own vulnerabilities and what kind of psychopathology and what kind of consequences they have it will lead on to. I'll not go into details because I'll come back later on this. And the treatment part is going to be enhancing the motivation for them to reduce the usage and use it more on essential part and reducing their recreational usage. And it also, the whole treatment has to be tailored for the patient's need. Each patient is very different over here, and their own comorbidity profile and the pattern of their usage need to be understood, and we need to work with them. So handling vulnerabilities, treating comorbidities, and also focusing on alternate pleasures need to be brought in. These are the basic principles, the 3 slides which I have put in. These are the basic principles in approaching the internet addiction issue at large. I'm going to focus more on the gaming disorder because that has a better literature than anything else. So we can discuss later if there are any other issues comes up. So to start with assessment of internet addiction, I generally follow this rule that an assessment has to be when people are being brought to our clinic, what is more evident is the psychopathology of the addiction, the addictive patterns that gets more prominence. What is the tipping point for them to reach to the hospital is about the consequences and complications which has happened because of that particular behavior. But so we are used to assess the psychopathology, and we are used to assess the consequences also because that's the reason why they had come up. But what is more important also is what made this person vulnerable to move into this whole addictive behavior per se. So if we are to do a formulation of this patient, it would be very interesting to look at in this fashion. Okay, this is a person with certain set of vulnerability, and this vulnerability led on to creation of such kind of psychopathology, and this psychopathology being there in this person has created certain level of consequences and complications in different areas of their life. The vulnerabilities again are 2 types. One is on the biological side, another is on the environmental side. We can go into the details of it a little later. And the psychopathology would be the internet gaming issue itself and all the other comorbid psychopathologies also. And the consequences because of the use of internet gaming excessively, what happens to them, how they lock themselves up, how they don't eat or eat excessively, how their whole skills getting affected, and how their academics are getting significantly affected. All these things would become the consequences part of it. So when we do the assessment and when we formulate in our mind, if we have this way of looking at it, like say start with vulnerability and then looking at the psychopathology, how it has developed and the consequences how later had come up, it will give us a fair idea about the holistic nature of the problem itself. In terms of the internet gaming and in the internet gaming disorder, what are we going to assess is very important. And I'll also tell why is it important to assess each of this. One of the major things which we have found very interesting is that the kind of sites they go into, the kind of games they go into are very reflective of their own inner self. And a lot of things in terms of their temperament will determine what kind of games they play. Not everybody is interested in everything. They have a very specific interest in particular set of games, and then they are very loyal to those games per se. And why is that is happening? Because that serves a purpose for them. So we really need to understand what is the type of what happens within the internet when they are being brought to us. Like say he's been on the gadget all the time. Now we really need to know everything what they are doing within that hour or whatever number of hours they are with the gadget, what they are doing within that, and how much time they are using it, and what is the how they are using it, like whether they're using it in mobile or console or in their laptop, how they are using this. It will also help us in understanding how we intervene later on. As in traditional substance use disorder, here also it's more important in terms of how this whole maladaptive way of using internet has developed and how is it maintained, what the factors which are allowing them to maintain such behavior is also need to be looked for. Many times it would be the fear of failure, the fear of not able to engage with their own colleagues, or the real life is very difficult for them. So there could be a lot of this. So these issues need to be sorted out, because this will be very useful when we start doing the therapy part of it. What is the positive expectancy which the person is having towards this particular behavior, or using this particular game? Because that will allow us to understand what function or what is the role which this one serves. Next is moving on to if they quit earlier, what is their reason for abstinence and how they move into it. All these things. This is traditional substance use disorder assessment, like, and what is their current motivation, and what are the things which needs to be addressed on an immediate basis. This is in terms of the psychopathology related. Now, when I talked about internet addiction criteria as such, this is Mark Griffith. Is one of the prominent researcher in the area of internet addiction as such. I mean, you can see a lot of, now Kimberly Young has moved out, and Griffith has the maximum number of publications on internet addiction per se. He has proposed this hypothesis of components model of addiction. And in the components model of addiction, he has given this thing. And this is self-explanatory. Salience is added, mood modification is added, tolerance is there, withdrawal symptoms are there, the conflict, the intra or interpersonal conflicts which is arising out of the internet usage, and the relapse. These have been added as a criteria to develop to name someone as having a behavioral addiction. One of the great critique of this whole internet addiction criteria, which was given by Griffith, is that the loss of control didn't gain prominence, and that's something is not acceptable to many other researchers. And there's a lot of debate which goes back and forth on why he has. Finally, he said that the loss of control could be subsumed under the conflict itself, the intrapersonal conflict itself. But not having loss of control had become a major issue with this construct. Now, we all know that DSM-5 had brought in this. The 9 criteria, which is on not on the main DSM listing. This is on the research section of it, and this 5 criteria out of 9, if it is satisfying, then they can be called as having IGD. This is it's a more of investigatory purpose. It's not gained the entry into the whole DSM-5 itself. The assessment of non-addiction-related psychopathology, it could be loneliness which the person going through. There is a sensation-seeking which the person has. What is the perceived level of stress in this person which could have contributed to, like, how much amount of self-control or self-regulation which this person has. And this is concept of experiential avoidance, where what happens is, in a way to self-regulate, one avoids certain negative stimuli, and use these aspect as use the behavioral addiction, whatever is the kind of behavioral addiction, for coping up with this the painful stimuli which is coming to their mind. High-risk behavior, one of the things which has been noted is the risk of deliberate self-harm and suicide are very high in this population too, and that needs to be meticulously assessed in this group. And the functionality part of it, which needs to be detailedly documented, and that will also help for the patient also to systematically look at their functionality, which may increase our rapport with this person. Complications, I don't need to go into the details of it. Physical complications in terms of strain injuries, vision issues, and posture and musculoskeletal issues which happens to them, and the withdrawals in terms of irritability and low mood, not motivated with things, and depression, all the kind of complications they go through. The comorbidity is something, there are 2 disorders that have been very commonly noted with internet addiction. One is ADHD and other is depression. There's a whole host of other disorders also being seen as comorbid with internet addiction, but ADHD and depression are seemingly at a higher thing. And those who have this comorbidity, their kind of gaming which they do are very specific and within their own interest. And medical comorbidity in terms of obesity, the other non-communicable diseases, hypertension, and they are more prone for it because they sedentary lifestyle, vision deficits, and chronic musculoskeletal issues they go through. The temporal sequence, if it is available, will be of use. Now, this is something which Dr. Ramakrishnan has pointed out in terms of family, how a family contributed to a psychopathology. And this is seen, it's not only in internet addiction, in host of all the problems which adolescents and youth go through in terms of addiction and other high-risk behaviors in this age group has its origin from the way the family has handled these issues, like family history of substance use and mental illness, both from the biological side and from the environmental side, how it has like parent interaction, single parent family. Most of the time, these are parental neglect happens over here, and the child doesn't have a proper interaction with the parent. That results in a lot of psychopathology, which they try to cope by getting into substance use or internet. Now, other factors include the support system, how other support system, both in the immediate family and the extended family also. Now, the adverse childhood experiences which one go through in the childhood contribute significantly towards the development of the psychopathology also. Generally, the physical and emotional abuses which one go through, the sexual abuses one go through, and being a victim of traumas are very important to be assessed in this population per se. And this can contribute both internet addiction and the other substance use also. This part I want to push it significantly, because what we have seen is that most of them have a vulnerability in terms of temperament, and their temperament are seemingly falling between either the internalizing group or the externalizing group. Externalizing group is where their distress is most often expressed outwards, and they seem to have more deviant behaviors. Antisocial personality disorder, ADHD, conduct disorder, ODD, all comes under the externalizing spectrum of disorders. And here the emotional instability is very commonly seen, and their high novelty seeking, low harm avoidance, high reward dependence is seen in this population. And this is not specific to internet addiction. It is with other substance use also, and it has been commonly seen in this population too. These are people who go more for the shooting kind of games, and their interest is into the violent games most often. So we really need to correlate the temperament and the games which they use. Internalizing pathway or internalizing spectrum disorders include low self-esteem, depression and anxiety, and a lot of the poor communication skills. That leads them to use the internet as a mode by which they can cope and run away from the real environment, which is more difficult for them to handle because of the lack of skills and on these internalizing spectrum issues. But these two are not mutually exclusive. What happens is when people have externalizing problems like ADHD and conduct on ODD at early age, what happens is a lot of negative feedback from the external environment comes, and they do develop low self-esteem and depression, anxiety also. And the same way, internalizing group of people have a reaction formation and have externalizing symptoms, which may be a little less common, but it can present. So these two are not mutually exclusive. Both can be present in this population. One other thing which is specifically found in internet addiction and internet gaming disorder group is the broad autistic phenotypic spectrum, the autistic temperament per se. They are aloof. They have very poor social skills, poor emotional recognitions, and there are stereotype behaviors in terms of interest in certain particular set of things. If this is seen, it's one of the very difficult. What we do is we find the other two temperaments initially and start treating them, but then we hit a wall and we are not able to move further. And then we go into the details of it and look at it. There are a broad autistic spectrum phenotypes which are being seen in them, and they contribute towards the course and outcome of this disorder per se. Now, there are screening instruments, quite a lot of it, and it's still many screening instruments are coming up. I don't want to go into the details of it. For the temperament also, there are things. I can share the presentation so people can look at it. What are these things like? So to summarize the assessment part, that we need to start from the vulnerability, both from the biology of the family history of addiction to the temperament and the environmental contribution in terms of parenting and the family pathology and the drug use environment or related environment, development of psychopathology and the consequences related to it. In the management, frankly speaking, the evidence base is inadequate. It has to be based on each person's problem and addressing each person's problem with our own in terms of managing the other disorders. Pharmacological management, these are agents which have been tried, and there are some studies which have been there. One of the agent is methylphenidate, which has been used because the ADHD comorbidity is very high, treating the comorbidity. Bupropion has been used for the same purpose, but most often all these agents are for treating the comorbidity. By treating the comorbidity, they are expecting that this behavior also will come down. Most of our work at this point of time is about the psychosocial intervention with them. Like, as I was saying, motivation interviewing is the key of creating rapport with this person and enhancing motivation of the person to stick on to the treatment. The cognitive behavioral therapy, there is a module which is being created by Young, which talks about around 18 sessions of how we go through each and every thing. Like, I couldn't get across a manual per se, but it's fairly okay, and it is relevant to what we are talking about till now. Again, relapse prevention plan, it has to be specific for this problem, but the principles are seemingly the same as what we use for the substance use disorder. Abstinence violation effect, I can say that I can relate it, because many times what we do is we do download games and keep playing it, and then we after a point we feel that like, oh, we are focusing on so much of it, and then delete it. Like, but then again it starts. When it starts, again that creates a lot of abstinence violation effect, and then we keep doing it. Like, similar thing which at a higher order that happens to these people also. Now, this is one thing which I will put more importance to, because if we are removing a person or asking a person to reduce the focus on internet, right? That's the source of entertainment or the recreation which the person had. Now, what is the alternative which we are going to create? If we don't create enough alternative, then the risk of them going back to it is very, very high. So we really need to work on the positive addiction or positive alternative behavior modules. Like, I usually use the concept of passion, where choosing something which I like and that has a value. For example, alcohol or other thing, they like it, but that doesn't have a value. But here, there could be from their past, whether there could be any positive behaviors which they like also could be elicited, and that can be added to gaming, so that instead of doing gaming alone, they will be doing this also. Family therapy is essential over here, because handling the expectancy of the family itself is very, very difficult, because they come with a lot of expectancy and they push us to see changes, but we are not having this issue. Second thing, the kids might come for the first session or second session, and they will not turn up for the from the second session or third session itself, they may not come up. So how do we handle that? How do we find surrogate therapists in terms of how do we use somebody in the family as a surrogate therapist, and they can be in touch with that, so that we can suggest techniques for them to do for some period of time until the person is willing to come back to the treatment setting. So a good family work is essential for management of internet addiction per se. And this is something which I couldn't find anything in India, but there are online Gamers Anonymous which is available. And I'd say like it's called Volga, and others. Anon also was there. Now, to summarize, when it comes for treatment, it's going to be the vulnerability will be taken up later. Consequences will be addressed first. Whatever is the consequence because of the whole internet gaming or the comorbid ADHD or depression, whatever has happened, that needs to be treated first. And then the psychopathology itself could be addressed. And finally, until unless we address the vulnerability part of it, like parenting or like other issues which is going around them, we will not be able to achieve a proper improvement. So the final slides on the prevention. See, internet gaming, basically speaking their language is important. If the kid is not willing to come or in the stage of developing addiction, it would be better to one of the family member to start looking at what is this game and how do we engage with this kid. Maybe one way of doing is starting to play with the kid itself. It may be difficult, but we don't have a choice. So starting to learn the game from them. And then we can actually speak their language better, and we can set mutually acceptable rules when they understand that, okay, you also know about it. Many times when we talk about it, their attitude is that you don't know anything. You're talking about it, you don't know anything, you don't do it. But then once we start engaging with them, it will be easy. And at least to look at the different ratings which are available. Like there are ratings in US, there are ratings in European countries, Russian countries. Like wherever the app or the game is coming from, we should actually look at the rating and the age group which is being given for using these games as such. Like one other technique which we can do is allowing the kid to play with the kids who are real life friends also, so that there is some amount of interaction which could be possible. And sometimes they can be called inside the home itself and they can start playing it. So yes, the game is there, but still we can at least engage them they can talk to each other and have some kind of real life communications too. Yeah, each game manufacturer give a different set of things. Then in terms of what's the monitor brightness, how much distance need to be there, what kind of gadget needs to be used, and all these things need to be looked and discussed with the kids per se. It's also very important to say that, okay, you can game, but you also need to pursue other interests also. This is more important when somebody is starting to use this. This is better pushed in. And in this COVID time, it has become a major hit because there's no other activities other than using internet is a part of it. So many of them have suffered significantly. There's this concept of brain-based parenting. It's about connecting with people early. It's not that once the problem starts, I will jump into helping and I will say that I am a friend of my son. No, that doesn't work, right? If you start then, they wouldn't be bothered. Why is he coming now? Is there something motive is there for him to come now? So until unless we start connecting early, it won't work, right? Sometimes what happens, we should help them to make decisions in certain aspects of it, like so that you can model them. You can actually share your frontal cortex with them in terms of problem solving. Sometimes you should allow them to solve problems for you. So an interactive way of handling the kids happens over there. Like sleep is something which needs to be monitored. Sleep is very, very important. If sleep is getting affected, that means there's something wrong is going on over there. It's also good to go along with other people in the school or in the environment who have been using games and internet, so that it is good. It is easy to understand what's the problem which is going on. And again, return to basics in terms of having family meals, and if someone one believes in spirituality and religious activities, they can go for that. Exercise and outdoor things. Just because we push them to do, they won't do it. Like we also need to do it. If we model it, then it's likely that they will follow it. The neighborhood and the community also need to be involved and helping the youth by creating opportunities for them to explore and unfortunately what happens is right now again in the COVID there's no much community involvement could be possible over here. I'll just skip on it because these are some things which are just how to healthily use gadgets. We have prepared that as an IEC for the younger lot. In summary, different models of interventions are used on whichever clinician is interested, they create their own model. But what is more important is that what is important for the person, and we need to titrate it accordingly. And involving all the stakeholders are very important. And we need to have more evidence-based interventions which should come up. Let's hope in the near future we get such a thing. To summarize, I said about how the assessment and the intervention needs to happen in what way. Yeah, just anyway. Thank you.
Thank you. Thank you both the speakers for the very comprehensive and the masterly way in which you dealt with your topics. We have almost reached our time limit, but still I think that we should take up a few questions. From my side, I think we'll ask the questions to Dr. Jayant first, and then Dr. Kandasamy after the first 5 minutes. First of all, thank you, Dr. Jayant, for the very, very comprehensive presentation. I have a personal doubt to be clarified with you. You mentioned about in the assessment part, the wearable devices to monitor a person's alcohol use, like mobile alcohol biosensors, etc. I would just like to have your comment on the ethical aspects of using such wearable devices in a person with alcohol use disorder. Just your comments.
Yeah, I think that's one of the very important areas that one needs to talk about. I think, yes, so definitely it is, where does that information actually go to? Who does that information go to, and what is it used for, which will really come about in terms of the ethical aspect. Obviously, if one is able to actually use that as a way for self-monitoring, then, so it's an individual who's actually consenting to actually utilize these devices, and then is willing to actually take it up as a way to be able to monitor his alcohol use. As we know, that helps. That is, having a feedback with regards to alcohol use is one of the important things in terms of intervention. In that sense, it would probably be ethically all right. If it is going to be about monitoring or tracking an individual without his consent, obviously it is ethically highly questionable.
Okay, thank you.
On a very good presentation to Dr. Jayant. What I like to share my view is, people, you talk about Gabapentin, Topiramate, Baclofen and all at high doses. Our patients don't tolerate. Gabapentin and Topiramate at higher dose gives sedation, cognitive impairment and other things. So what is your experience about these molecules? And again about the N-acetyl cysteine, what is your, and another aspect what I wanted to tell, most of the people with alcohol dependence syndrome, what we call, many people are depressed. How about treating depression? Because as you know, 1/3 of the alcohol patients at the end of the day commit suicide. And depression is one of the commonest comorbid, or cause. It may be cause or effect. Alcohol may be a cause or effect. What is your opinion?
Thank you, Dr. Ramakrishnan. I'll take your questions one by one. So with regards to the first question, with regards to tolerability, obviously, sir, I completely agree with you. I think ultimately it is going to be based on tolerability. You're right that even in our population, we don't usually go up to the recommended doses that are mentioned. Although we like, say, for example, for Topiramate, typically the doses that we use from our experiences around 150 milligrams of Topiramate. So 200 to 300 mg, although that is what has been tried in many of the clinical trials, we don't typically go up to those doses. Gabapentin, again, in the individuals in which in whom we have tried using gabapentin, between 900 to 1200. And that's why I was saying there's a whole host of studies which point towards a range of doses which are used for gabapentin. So obviously, again, it is something which would need to be optimized. Baclofen, actually, surprisingly, while there have been a lot of concerns with regards to tolerability, we have been able to, as I said, give fairly high doses in certain individuals at least, and they are able to actually tolerate, I mean, as I said, 150 up to 150 mg of baclofen as well in certain individuals. But obviously that has to be based on a titration schedule. We don't immediately go up to those doses. Our typical doses are up to between 60 to 80, and then subsequently after that we titrate the doses up if there is inadequate response despite good compliance with medications. Now, with regards to your second question, sir, again, I think it's very important because comorbid psychiatric disorders are very, very common, and depression is one of the very common comorbid psychiatric disorders. So there are two things that one needs to mention with regards to that. If there is an independent comorbid depressive disorder along with alcohol use disorder, there is some literature which has looked into what helps with regards to that. So combination, I mean, at least based on the trials, I'm just telling you as to what is there. SSRIs seem to be helpful in that context when there is a comorbid alcohol use and depression. Now, the flip side to that is there are some studies which have looked at using SSRIs independently in people with alcohol use disorders, not necessarily with depression. I mean, so again, in the context of alcohol use disorders, depression can present in many contexts. One, as you had mentioned, is that there is a pre-existing depression which actually leads the person to take alcohol. The other is this profile wherein you have an individual with long-standing alcohol use with a lot of consequences, lot of other complications that has occurred and developed depression. And then, of course, there is those individuals who have the so-called alcohol-related mood episodes, wherein you will have depressive symptoms in the context of withdrawal or protracted withdrawal. These are the three scenarios in which we usually see them. So in individuals where there is a pre-existing depression, which we are there to suspect along with an alcohol use disorder, certainly, I think treating with an SSRI, and I think SSRIs have the best evidence. Sertraline is what has good evidence from trials. Your TCAs don't seem to have very good evidence, both in terms of efficacy as well as safety. But in other cases where you're looking at alcohol use disorders and probably depression in the context of withdrawal, there you would actually have to look at some of these other agents which we are talking about, which handle withdrawal negative effect kind of symptoms rather than just SSRIs. So,
thank you. There are some interesting questions, but I think we need to cut on certain questions. Just a brief query by Dr. Rajmohan from Calicut on the use of N-acetyl cysteine. He has a specific query what is about the experience and use of N-acetyl cysteine in addictions.
Okay. So specifically, although there is some literature in alcohol use disorder, we commonly use it in cannabis use disorders, and that is where there is probably, as far as in the realm of addictions, that is where there is the maximum evidence. And the doses that are used are anywhere between 1800 to 2400 milligrams of N-acetylcysteine. Usually, they are available in the form of these capsules which can be emptied out into water, and they are taken either twice a day or 3 times in a day. That is what we usually use for cannabis use disorder, and there is some preliminary evidence that it helps with reducing the number of cannabis negative urines in individuals with NAC. But again, it's fairly preliminary. There have been mixed findings with regards to that. In alcohol use disorders, it's even more preliminary. So that's what I would say. But again, there is no harm in that sense. NAC is not particularly a molecule which has any major adverse effects. So that's one thing that is okay.
Thank you. Dr. Sindhu Rajesh puts across a question with regard to the safety of newer agents in the background of liver disease, especially hepatitis B. maybe most of these agents, most of the patients with alcohol use disorder could be having comorbid liver disease. So she wants to be clarified on that.
So Baclofen is safe, Gabapentin is safe, Ondansetron is safe. With regards to, and like traditionally we know that we don't give naltrexone and nalmefene. Nalmefene is relatively more liver safe. And what are the other agents that we give? Yeah, camprosate, of course, is something that we use, amongst the classical agents. So,
okay, thank you.
Gabapentin are both safe.
Yeah, thank you. That clarifies that. Dr. Vidhu, are you moving on to, can you move on to Dr. Kandasami's topic? Are there any questions pending from? Okay, so there has been very interesting questions. Dr. Kandasamy has made a very difficult, very tough topic, very lucid, and a lot of clarity has come out after listening to you. A lot of participants have appreciated in the chat box. A few specific questions, mostly some of them comments. Dr. Manik Singh asked Dr. Kandasamy whether we should be continuing to use the term internet addiction disorder. Why not we change over to a less problematic term, like problematic internet use rather than internet use disorder? So that is one question coming from Dr. Manik Singh. Your comments on that?
Sir, again, this is a term, internet gaming disorder is the term which is being used by DSM-5. Before that, like this PIU was there, IGD is which they are using currently. Earlier, it should be, it was PIU. There are so many names which people keep using it. Personally, I don't feel that it's a problem in naming in any of these names. What is if you ask, I think there was one other question in terms of experience in treating internet addiction. Maybe Jayant can correct me. Most of the clients whom we had seen over in this place had one or other comorbidity with them, and all of them have temperamental issues, definitely. Yeah. But they primarily have other comorbid issue also. So it's more important to handle things as whole. Any of this terminology, it's only for us to communicate to each other. I think it's also about the lobbying which happens in the WHO and in the DSM-5 group meetings, where what terms need to be used. Otherwise, it doesn't make much difference as such.
Thank you, Dr. Rajkumari Linthosina. I don't know whether I got the name correct. She is asking whether how often, or the relationship between the musculoskeletal problems and the visual problems and the internet addiction. How often you come across, and could there be a relationship?
Sir, it definitely is a problem as such, and that too in this group, in terms of how long one is looking at the, in terms of ophthalmological, it is how long one look at the monitor, at how much distance they look at the monitor. It matters, and whether it is mobile or it is laptop or it is desktop, there are clear-cut directions about how much. Say 30, 40 and 50 centimeters have been suggested for mobile, laptop and desktop. This is a larger, but many of even us also, we do have it quite nearer, and that ophthalmologically is a problem which will eventually happen. And the blinking, the number of blinks are very less over here, so the dryness of the eye, which happens quite often, and that results in this whole computer vision syndrome and the redness which happens to them. Now, all these things could be avoided if there is a break in the work or whatever we are doing, and we can have a gap of every 20 to 30 minutes. Having a gap would be good. In terms of musculoskeletal, again, the posture is a problem. Now, many a times when we work with laptops and desktops, that's not at the vision level. We are allowed to bend, and our spine is taking a different toll. I forgot to put that, how we started from a monkey and moved again towards bending the spine now in terms of looking at our mobile. So that leads on to a lot of musculoskeletal issues, and there are quite a few guidelines in terms of what you should do, what kind of stretches you should do once you sit in the same place for a long period of time, in terms of sitting in especially in the IT industries, what kind of chairs you use. All these things has been gaining importance.
Sir, my question, sir.
Yeah.
Sir, very good topic, and elaborated in depth about the internet addiction. My question will be, what is your success rate? How many patients have you succeeded in treating and making him abstinent? Number one. Another thing, does inpatient care for a month, like how do you do for alcohol addiction or cannabis addiction? You do inpatient care. Is it worthwhile? And another thing is, we always in alcohol we are worried about relapse. What we suggest, other people should not take, in the family should not take alcohol. He should not be exposed to places where people take alcohol and other things. But the boy or the girl who is addicted to internet has to face a similar situation where the parents and other sisters are also used. So the chances of exposure again is same. So unless there is an inner motivation to come out of this addiction only, there will be solution. This is my idea.
Definitely. So in terms of your first question, to look at the success rate as such, like as in addiction, other addictions also, it's very defined the success rate as yes or no over here. Like it's a long-term work which we do with them, and what the success rate with the client is based on what kind of comorbidity they are presenting with, and if we are able to address the comorbidity properly and start working with learning the skills which they have not learned. If it happens methodically and the patient comes to us on a regular basis, he or she trusts us and come on regular basis to us, there is I would say their problems are reduced. At least 60 to 70% of their problems are reduced, and they start living their life better. Now, I can quote one of my clients whom I'd seen in 2011. Today, luckily, on February 1st, he has joined MBBS. And because of his sheer persistence, and he continued to this thing, then he shifted his motivation from, he also had a recurrent depressive disorder which was not identified. He has had parental conflicts in terms of parents separated, and his own self-esteem in terms of being obese and dark. All these things had contributed to his behavior. We started addressing one by one, and it took a long time. I would say that it took at least 3 to 4 years for working with him to find the success, and the sheer persistence with the treatment, he could lead up to this day. And there are clients who haven't bothered to visit again also. Like, so this happens with all that addiction. I would say the kind of comorbidity which is there with them and their willingness to work, if you have a better model to work with them, its success rate is high. The second question is on the inpatients. This is a very tricky population, sir, because younger the lot, their willingness to get admitted is very low, and because it's restrictive environment. When it is restrictive environment, their cooperation goes down. So what we do is, initially we'll negotiate with them in terms of doing the outpatient treatment and how things are going. While this is happening, if we could create a better rapport with them and we can convince them, then we can go for inpatient treatment also. But again, whether it is inpatient or outpatient, the treatment has to be for a longer term. So either ways, it's based on the need we decide on it. But generally, the younger the client, let's say under 18 and thing, it's very difficult to admit with us also. The third observation, how the motivation matters. Yes, definitely, sir. Until unless the person is motivated, it's going to be very difficult. And this in this population, as I pointed out, majority of them will come with at least 60% of them will come pre-contemplation or contemplation, and they wouldn't be in a preparatory phase at all. And it increases the difficulty of our tasks every time. But yes, we don't have a go. But whenever they are motivated, it works very well, as you pointed out.
And I just want to have some comments, Dr. Karun. You just mentioned about the cyber sex addiction and pornography, so which is into the limelight of many children these days. Many parents come and give many dark gray area about this, and many of the extramarital affairs are more coming up with the social media usages. These are the things which have to be prominently addressed. I think from the Indian population, we have been seeing the Western culture so very often, but now in Indian population and the young adolescents with those spouses working abroad are easily having contact, and we're getting number of cases with the groups of WhatsApp group and other social media groups, and it has become a routine common cases in our clinic, in day-to-day clinic. So whether we can classify these people as like a social media internet addiction disorder or some other adjustmental disorders, we are not very much sure, right? And one more, just one comment, like for the last 1 year, all the childrens and most of the adolescents have been using the internet platform as one of the criteria for their educational purposes. And it is very difficult to conclude that right now we can classify all these peoples will classically fit into the IAD. So many of the parents, those who are visiting to me, I just tell them a simple advice is that just wait and watch till the next academic session gets opened when the school starts. So this is my personal opinion, rather than starting on any medications or any psychosocial interventions. So that will be my personal experience on that. What about your comments on this cyber sex addiction and social issues?
So, I would agree with you because this is something which is not new. Even when in the descriptions of different kinds of internet addiction happen, cyber porn and cyber relation issues have been prominently described. I didn't take it up because that itself takes a different turn on how do we treat them and what do we do with them. There is also this internet infidelities which you talked about. These are very I would say this accessibility and anonymity makes people to explore a lot. Now, in a society which is a little punitive and doesn't allow people to experiment or explore, they will definitely move into this. The younger lot, I would say the other problem is, even if they don't have any psychopathology, there is no clarity about how to use social media platform. Not only for the younger lot, even for the older lot also, we don't have much idea how to use it and what is the sanctity and discipline with which we respond to mails as such. Sharing their pictures, sharing their every time to time what they are doing, where they are going, and some of the kids get into trouble in terms of sharing their pictures which are half nude or nude pictures, which goes into the internet and creates a lots of problem. Now, this is one thing which needs to be addressed at the school level in terms of what is the healthy way of using internet, what should be done, what should not be done, and I would one of the best intervention material which I had come across is the Hong Kong's primary education department has created a manual for both the adolescent teachers and the parents also in terms of what are the risks. And they've actually both the physical side and the psychological side and the social side, and what kind of intervention needs to be done on both sides. How one should keep oneself safe in different kinds of environment. Like say, bullying is something which happens, which you mentioned. The issues about one's own body shaming. All these things are happening over internet, and we as adults are not very much exposed to that. But in the children's mindset, it affects a lot of to a lot extent it happens as such. And these are some things which needs to be pushed in as healthy and safe internet usage behaviors had to be taught. How we are reluctant in terms of talking sexuality quite often, Now, but at least this is not that very difficult when compared to talking about sexuality. So it is becoming like food. So it's better that start talking about what is the do's and don'ts in terms of using internet. That will help to some extent to reduce the pathological form of usages. Pathological forms are always there and it needs to be handled. We do get quite a lot of people who come with those issues also. In terms of, sir, even your advice for them to wait and watch and be observant is a psychosocial intervention. It is important to handle them also. Many times they are anxious about certain things. Now, what do we do? The whole thing has moved into online platform. What will the kids do? They are also not to be blamed. And when the children are not being watched by the teachers, they keep switching over to different windows, right? How much the teacher can look at 40 kids in a Zoom classroom? It's becoming very difficult for the teachers also. No one-on-one interaction. It's a very, very difficult time, sir. And the effect of it, we might be able to see. Luckily, the long-term stability of the diagnosis of all the behavioral addiction till now reported is not that very great. This is another reason why that didn't gain more is very low. So I'm hoping that these kids who didn't have the psychopathology and had to use this stuff for learning, they would be able to get back to their normalcy if the normalcy returns. But the kids who are on the border, on the cats who were on the wall, they are at a high risk, and we may be getting a lot in the next 6 months to 1 year. We will be getting a lot of problems with them, especially once a school starts and every college start. We will be able to see a lot more problem. This is my assumption.
Okay. Now it's time to conclude. And we had two great erudite presentations from the Premier Institute and the Premier Institute in Addiction Medicine. And Dr. Jayant basically discussed the pharmacology, recent advances, starting from the established evidence-based medications to the experimental ones, which are to come during the last 10 years. And Dr. Arun actually has discussed how a client with addiction, internet addiction, should be, the assessment should be personalized, taking into developmental levels, vulnerability, etc., and how it should be individualized and personalized. And thanks to both speakers, and also I thank on behalf of me as well as my co-chairperson, to Dr. Ramakrishnan, Dr. Aravind, and all the participants who had been part of this webinar. And thank you all. And over to the organizers.
Thank you.
Now it is my time to honor the two great speakers on behalf of the CME committee, WISER committee, chairpersons and IPS Southzone. It is my pleasure to honor Dr. Arun Kandasamy. Thank you, sir, for your excellent lecture. Thank you. And Dr. Jayant Mahadevan, thank you, sir. This will reach you in 2 days. Thank you so much for being so kind to us and spend your time for these two extraordinary lectures. And I think the clinicians and postgraduate students have benefited much from this topic. Over to Dr. Aravind?
Yeah, I think Dr. Dayal is not there, so I'll just let me conclude the session. Okay. So on behalf of IPS Southzone CME, we are organizing in a very right flow of the 4th month program, and it's been an honor to have two distinguished chairpersons from Kerala, Professor Varghese and Professor Vidhukumar, and I would like to thank the professor individually for accepting our invitation and sharing the session of today's webinar, virtual webinar. And the speakers of our today's virtual webinar, I would like to thank personally to Dr. Jayant and Dr. Arun Kandasamy, who had given an elaborate explanation of two kinds of addictions on internet addiction and the alcohol addiction, the recent advances. And I would like to thank the EC members, the South Zone Committee members, my colleagues and the friends and postgraduates and other clinicians who have been viewing this virtual webinar and got benefited from this learning material. I thank you all and have a good night. Thank you very much.
Thank you. Thank you.
Thank you.
Arvind, can you hold for some 2 minutes? Has Arvind gone? Arvind, Sai Krishna. Arvind, are you there? Sai Krishna.
Given a message to him. He told he'll call me in the morning tomorrow. So once he talks to me, I'll just get back to all the committee, Southzonal committee members and put the issues regarding the topic and theme of the CME.
Yes, sir.
Okay, so I've already given a message in the evening itself before the start of CME. He told that he will call me tomorrow morning as he has got some personal work.
Okay, sir.
Okay.
What theme we can have this time, sir?
So let me have a discussion with Vishal, but he may be having something in his corner of his mind. So whatever it is, let's just define that, sir. Okay.
Okay, okay.
So we'll just give hands to the organizing team. So let them also work on that. So not everything will be taken care of the CME. CME will be side of the midterm CME organizing committee team, and in par with that, we will just come and conclude the team and speakers and chairpersons.
Okay, sir. Okay.
Okay.
Thank you. For that only, I just want.
Okay, sir. Okay. Thank you. Okay.
Yes, sir. How are you, sir? Thank you.
I'll get back to you once he speaks to me, sir. Okay, don't worry.
Okay, sir. Okay.
Okay. Thank you.
Thank you, sir.
Thank you,
sir. Sai Krishna, another one help.
Yeah, thank you, sir.
I asked Mr. about the members who attended the AGB in Hyderabad.
Sir, it is with Dr. Minat, sir.
Yes,
Minat, sir, will forward to you, sir.
Yeah, he told that he will do it, but so far not got it.
I'll keep a reminder, sir. Tomorrow morning, I'll personally ring to him and ask, sir.
Sorry, sir, in this juncture, I want to ask you.
Yeah.
Since it is an online AGB, do we require all the names who attended, or it is a thing?
Yeah, we can. Everybody should join the meeting with their like membership.
So at present we don't have the list of who joined, sir.
I think the treasurer will be having the list.
Yes, sir. That's what I have been asking, sir. But he told the organizer, the technical man, he will what this thing, they delete the mail and all. He's telling.
No, we should be having the updated list for the last October, last election. That's on June 2020. So that list will be there with Dr. Gangaram, and in addition to that, will be the new additions later.
No, sir. About
after June.
No.
So I don't think it should be a problem.
No, in Hyderabad, the members who are present in the AGB to write the minutes of the AGB. That is.
That should have. They should have noted down the names of the participants there, and both in the in person as well as online.
Online, they didn't write down, sir. I am asking, and just what I remember reminded Sai Krishna to see if it is possible.
Sir, I'll speak to Dr. Minat, sir, and I'll update you, sir, tomorrow morning.
Okay. Who are physically there, I know. I remember 30 members were there, which we can name. But other 57 people, I think, joined in the virtual mode. But I don't know.
I think the organizing people will be having the recordings of that AGB minutes.
They got the recording and they sent their audio, sir. But then what the problem is, the names, beside it comes no chat. In that here only the people who attended will come. That they are not given. That is the problem.
They don't have the screenshot?
Yes. I doubt it. In memory, we can write, sir, who all participated and all we can write. But 100%, I'm not sure we can do it. We'll think of it, sir.
What about the next AGB? How are you going to for the attendance, sir?
AGB.
Yes, sir.
At the time, I will make it available, store it, everything.
Okay. Or we can make it as a Google form and ask them to first initially fill it and send it to you, sir.
Yes,
so
sir.
that you can have that documented written or mail document.
Exactly.
Okay, we can do that. That is better. Yes, sir. 10 days before, we can just ask them to send it to all the members of the IPS Southzone and ask them to send it so that we can get the list of the numbers who are going to get attending.
On the same day, we will again take a count on who.
Can we ask them to fill it up just at the time of joining the AGB?
Yes, sir. You can do it on the day or half day of before, sir.
On the day of AGB, we can ask them to sign.
Yes,
before
sir.
they
Yes,
join the link,
So we'll
they
make
had
it.
to, fill up the form and join.
yes, sir. That will be better, sir. Initially, before giving it earlier, it will be better if you give it
And
on the
in the
day.
chat
Sir.
box, let them, and in the chat box also let them join the left number.
Yes, sir. Yes,
Yeah.
sir.
Yes, sir.
And we'll take a screenshot also.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. Okay, sir. Okay, sir. Thank you so
Sir,
much.
The problem with the screenshot is that most of them they use the telephone, mobile device rather than the name. That's the only problem.
Most of them are carrying only the mobile phone devices rather than the name or the photos, profile pictures. That's a problem comes, sir.
Yeah, that's
It's very difficult to track the mobile numbers, sir. Yes, sir. So we can formulate it, sir.
The best thing is just before joining the AGB,
yes, sir.
before they enter room, I think they form and then enter.
Yes, sir.
If we can form something like that, then that will be better.
However, it is possible, sir. Not a problem.
And in the chat box also that.
Yes, sir. Thank you, sir. Thank you.
Thank you. Thank you, sir. Thank you. Thank you. Good night.
Thank you, sir. Good night, sir.
Okay.
Good night. Good night. Good night, Sai. Good night.
Good night, sir. Arvind, sir. Good night, sir. Ramakrishnan, sir. Sir. Thank you, sir.
How is Dr. Kishan? He is not coming. He's busy.
He's fine, sir. He's fine, sir. He's busy with IMA activities, sir.
IMA. He is gone to IMA from IPS.
Yes, sir. Yeah, sir is vice president, sir. And against Mixtropathy, there are a lot of rallies and programs, sir.
That's what
So sir is busy.
From IPS, he has gone to IPS.
Yeah, IMA, sir.
IMA.
Yeah.
Okay, sir. Okay, sir.
Yeah. Thank you, sir.
Okay. Okay. Good night.
Thank you, sir. Good night, sir.